Hi everyone, I'm Brittany Orlebeck from Chapin Hall at the University of Chicago. And in this session, I'm going to go over some basic principles about designing and making decisions about evaluation. My goal is that after you watch this session, you will have a framework for thinking about what and what kinds of evaluation make sense for you and your agency. The PowerPoint, along with the accompanying workbook, will be available at the Northern California Training Academy website. There will be 2 points where you can pause the presentation and do the exercises in the workbook, or you can do the exercises at the end. At any point, you can also consult the workbook answers. An evaluation is the structured inquiry into the value or condition of someone or something that is summarized in a written report that can be shared with others and retained for the record. Commitment to an evaluation usually involves the explicit allocation of resources, sometimes substantial, often involves researchers outside the agency, and an expectation for a more comprehensive and in-depth written report. To get what you want out of an evaluation, you'll need to apply all of the lessons learned so far in these CQI sessions, especially those about selecting the population. I'll go over those key concepts again. At this point, let's also remind ourselves about the types of evaluation. Implementation evaluation, we all know what that is, also sometimes called formative or fidelity. The cost evaluation, how much the program costs, both direct and indirect, like the cost of administrating the program. Outcome evaluations, looking at the impact of a program. And cost effectiveness evaluations, which combine the result of an outcome evaluation with the cost evaluation. So the most comprehensive evaluations will include all these types, but not all evaluations need to include all types. Some evaluations will only be about implementation. There's an exercise in the workbook to help you think about these evaluation types. You can pause and complete that now if you wish. Take a look at this now familiar graphic of the CQI process, focusing on the study phase. You might be asking yourself, doesn't every plan, do, study, act cycle involve evaluation? Yes, the study phase of any CQI cycle should involve a report of some kind, maybe a memo or a short report. But evaluations are labor intensive and extend over a longer period and typically involve more resources. If you want to evaluate a program or reform or administrative change that is already embedded in a CQI process that follows these best practices, then the initiative will already be structured to incorporate the critical principles you've learned so far. There's a lot of value in that. If you're looking to evaluate a program or process that is not embedded in a Plan, Do, Study, Act process, then you have to assess those questions before going forward. Either way, let's review those best practices, and you can review those videos as well. First, we have Know Your Question. That was from Module 1. Second, who is in the denominator or the risk set? This was covered in Module 3. Select a representative sample, usually a group entering the program, the entry cohort equivalent. This was covered in Module 4. And finally, pay attention to the window from Module 5. Make sure your evaluation is going to extend at least to the point where you expect the program to have an impact. All these questions should have been addressed if the evaluation is embedded in a Plan, Do, Study, Act cycle. But what if there is an interest in evaluating a program that is already started or is done, that was not embedded in a Plan, Do, Study, Act cycle? Then you'll have to go back and address these 4 principles. The bottom line is this. If you cannot apply the CQI principles presented so far to an evaluation, it is not worth doing. There's an exercise in the workbook to help you think about following best practices for defining the population for an evaluation. You can pause now and complete that now if you wish. Critical to the design of an outcome evaluation is the ability to replicate a comparison population using the same criteria by which the population is chosen to receive the treatment. Here are the 4 basic options. We'll add one more before the end of the session. We have randomization, comparison group using group of kids in the agency during the same period, a comparison group during the same period outside the agency, and comparison to a comparison group that looks at historical kids that were served by the same agency. Let's go through those one by one, since they're so important to understand. So number one, we have randomization. This method for creating a comparison group is only a good choice if there are enough children to randomly assign to a comparison population, and only if properly implemented. If you are either planning to serve the entire target population and/or do not have the incentive or capacity to operate an adequate random assignment design, it's not a good choice. With many new interventions, including evidence-based practices, it's enough to get caseworkers to refer any families or children, much less enough to generate both a treatment and a comparison population. Without incentive and capacity, even the clearest assignment and service delivery protocol is likely to be violated, often enough to doom the experiment. So you're left with the other three basic choices. And all of these share the threat of unmeasured differences. There's unmeasured differences at the client level. All three potentially have this issue. There is unmeasured differences at when you have this issue at the client level, you can control for them using standard regression or propensity score matching, depending on how many variables you have and how good they are at identifying the population that you're studying. Then there's also unmeasured differences in agency practice and culture. Comparison agencies and counties have this issue. This is the second option, or the third option. This is a significant threat that is very difficult to control for, even with multiple agencies on both sides. Basically, clients in the treatment and control groups are nested in groups that share practice and community cultures at the agency level that could result in differences in outcomes that don't have anything to do with what's being evaluated. Then there's unmeasured differences based on time. This is an issue for option 4, historical comparisons. But in many cases, communities and agencies just don't change that much that fast. There's a few other evaluation-specific issues that I want you to be aware of. The first is this idea of an intent-to-treat design. Most evaluations should include everyone eligible to receive a given treatment or intervention in the analysis of treatment outcomes. That means that regardless of refusal, noncompliance, protocol deviations, withdrawal, or anything that happens after eligibility determinations are made, should still be included in the target group. Because we all know that noncompliance and protocol deviations are likely to occur in actual agency and clinical practice. So most evaluations of social services programs should be done using this intent to treat model. Be very wary of evaluations that only look at the group that actually participated in the program. It's probably a biased sample. And the outcome of interest. How prevalent is it? You should always try to estimate the baseline occurrence of the outcome of interest in the target group before finalizing an evaluation design. For example, if the incidence of placement in the target population is only 10% and placement reduction is an expected outcome, it's a high bar to reduce that further. Power is a subject unto itself. Before embarking on an evaluation, particularly one using random assignment, researchers will typically estimate the minimum number of subjects necessary to find a hypothesized effect size. There are various internet power calculators that you can use to do this. Finally, think about dosage. For evidence-based interventions, this is usually specified. So now we're going to talk through an example using parent-child interaction therapy that's going to use some of the concepts that I've just talked about. Let's imagine that this is an excerpt from the county's evaluation plan for parent-child interaction therapy for implementing this program in their agency. So it's going to read something like this. We are implementing PCIT in our county and want to evaluate its impact on the likelihood of placement in foster care. PCIT will be available to families where children between the ages of 2 and 8 are found unsafe without home-based intervention on the risk assessment and scored an X on Y CANS elements. For these clients, during family team meetings and other clinical decision-making points, families in this category will be considered for referral to PCIT based on factors known to agency staff, but not necessarily captured in administrative data. So this county is doing pretty well so far, just with these two paragraphs. The question is clear, impact of PCIT and the likelihood of placement, and the risk set is clear. You can imagine how an entry cohort can be constructed to track what happens going forward for a group of eligible families. Only the specification of the window is missing, but that could be added later. So as we think about this idea of the referral group and the intent to treat group, we can see that for this county, the intent to treat group really is the group that gets referred, but we don't have, that's essentially a clinical decision. So we're not going to be able to replicate that same clinical decision for this evaluation. So we have to back it up a little bit farther. We have to back it up to what's specified in the first paragraph. So the target group is going to be children during the calendar year who were found unsafe without home-based intervention on the risk assessment and had these scores on the CANS elements. And then from that point forward, the decision is a clinical one. So let's map out the implementation expectations for this program. And this is the kind of thing that we're advocating that you do as well when you're thinking about undertaking an evaluation. So we know who the target group is. It's children who are going to enter during the calendar year who were found unsafe without home-based intervention on the risk assessment and scored the specified scores on the CANS elements. And we know that from that point forward, it's going to be a clinical decision to decide whether or not children and families should be referred. So we can map this out in the following way. This first box represents the target group last year during 2014. This second box represents the target group in 2015 when we start the program. This third box represents the target group in 2016 and so on. So the way you should think about those boxes is that they represent 100% of the target population. So let's see what happens in the first year. We expect that 20% of that target population is going to be referred to PCIT, and that 10% is actually going to start PCIT. And then the next year, as caseworkers get to know and trust this service a little bit more, 30% are going to be referred to PCIT, and 20% are going to start PCIT. And finally, after the program has been running for 3 years, we are able to refer 60% to PCIT and 50% start PCIT. So you can see a couple of things that your implementation evaluation will be interested in and will want to track. This is just our hypothesis, but you'll see going forward whether or not this actually holds true. But by going through this process up front, what you're seeing is how much of your target group are you actually going to serve? And if those blue boxes, either of those blue boxes was well below 50%, even in the 25% range, it's probably not worth trying to do an impact evaluation. So we're going to use this example to talk through the comparison group options that we presented a few moments ago. So randomization, is this a reasonable choice? Well, you would have to randomize after the clinical decision is made. Is that reasonable? Is that something that your agency can take on? Is that something that, would you have enough children and families who are able to meet that clinical criteria such that you could divide them into two groups? If you can, that's the best way to control for these unmeasured differences. How about comparison in the same period within the agency? So you might ask, why not compare the blue group to the white group for the same entry group? So that would be either in 2015, 2016, or 2017, looking at that little slice of kids that were referred but families that were referred that didn't take up the program. And that is the worst idea. You already know the groups are not equivalent on the very characteristics you care about and can't measure. Why did some families take up the program and not others? Why did the mental health agency screen out some families and not others? So that's pretty much the worst idea that you could choose. How about the third option, comparing outside the agency to try to find a similar group of kids? But can you identify an agency whose culture and clients are virtually equivalent, and who is also going to be able to implement the same targeting criteria with the CANS elements that you've chosen? Probably not. Finally, we have looking at a historical period in the agency. Would you expect the targeted children and families that come to the agency's attention to be equivalent from 2013 to 2015? If yes, this is the best choice. So let's just see how that might work. So in that first box, the 2014 target group, there was no PCIT that was available. And if those kids are basically equivalent to the kids that were placed in who met the criteria in 2017, where 50% were served by PCIT, then you have the possibility of making a judgment about whether or not outcomes improved for that group as a whole. And again, that's not going to make a lot of sense if that blue slice is very, very small. But the larger the blue slice, the more that historical comparison group can really make a lot of sense. Then there's a fifth option, and basically the fifth option combines the outside agency with the historical groups. So in this way, what we're doing is we're looking at both within the agency historically and other agencies historically. And what that does is it allows for better control of temporal changes and more robust measures of clinical covariance. But again, as soon as you start talking about working with other agencies, other counties or other private agencies, you have to make sure that those agencies are going to be selecting the same target group. And if they're not participating in the evaluation, what kind of incentive do they really have to do that to your satisfaction? So let's review the threats. Again, this is just on the outcome evaluation side, outcome and cost effectiveness. We have the poorly defined, overly broad target population. We have low treatment uptake or dosage. We have randomization violations if that's the comparison group that you choose. We have unmeasured differences at the client level. Again, a lot of folks talk about propensity score matching, but that only works if you have enough variables on which to match the clients and you don't have the threats of other unmeasured differences. Like, for example, the next one, agency practice and culture. And finally, we have the unmeasured differences that are related to time. If you're thinking about undertaking an evaluation, you really need to review an outcome evaluation, really need to review all of these threats. So this last box is also in your workbook, and we're going to have some questions that allow you to work with this last box. And basically what we've done is we've taken what we've learned about the five comparison population options, and they're listed across the top, and then we have the threats listed down the side. And I don't want to spend too much time on this right now because we're going to, as I said, it's going to be in the workbook for you to work with. But what I want to point out is that those top two rows are significant regardless of your comparison population. So if you have a poorly defined, overly broad target population, a random assignment evaluation is not going to solve that problem. If you have a problem with low treatment uptake and dosage, random assignment is not going to solve that problem. So that's one point I want to make with this. And finally, if random assignment is not something that's possible, and there are lots of circumstances where it's not, you are left in this bottom box here, trying to make a decision about these different comparison population options. And what I want to leave you with is the fact that only the comparison population that includes the historical comparison has the fewest number of threats. So a couple of final words. If the comparison population that an evaluation is relying on is most likely different from the treatment population, it's probably not worth the investment to document a difference that had nothing to do with the intervention. Why not spend those resources studying implementation? Think about one of my first points. Written results from a well-crafted implementation evaluation can be the most informative for staff at multiple levels of the agency. There is one more exercise in the workbook for you to complete. Next, we'll be talking to Bridget Leary, who is a senior policy analyst at the San Francisco Human Services Agency. And she's going to tell us a little bit about doing evaluation in the real world. So Bridget, folks just finished hearing about evaluations and some of the threats to different designs, different types of evaluations, and we wanted to talk with you today about your experience with doing evaluations in the real world. So why don't you start out by telling us a little bit about what you're doing right now and how you came to that position?
Sure. Right now I work for the San Francisco Human Services Agency, where I oversee research and evaluation, primarily in the child welfare department. And I came upon that position in a bit of an interesting way. I started out in a place that many county folks are familiar with, the Center for Social Services Research at UC Berkeley. And in my doctoral program there, I worked under Barbara Needell, where the California Child Welfare Performance Indicators Project is based, and that website that's publicly available containing all the child welfare information for children in California. And so I really cut my teeth there learning about how to do child welfare research. And then I went on to work at Chapin Hall for a number of years. And in that position, I did a lot of research and evaluation for various jurisdictions around the country. And then decided to take a local position to really get into sort of the trenches and learn more about what it's like to conduct research and evaluation really in my hometown, essentially, which is San Francisco. And so it's been a really great experience over the last couple of years to learn about sort of doing the same work on behalf of the same populations, but really just the other side of the table. So being an internal person.
Yeah, wow, so you've got some great experience, like you said, on both sides of the table. So in the lecture, we talked quite a bit about this targeting issue in evaluation, the issue of defining the right population that's going to receive the intervention, and then also defining that same population as a comparison group when you're doing outcome evaluation. And I understand that there's been some experience lately with the wraparound program for teens for troubled teens, and that targeting has come up as an issue. Can you tell us a little bit about that?
Sure. I think it comes up in any number of interventions that one is trying to implement. And the issue can be around implementing an intervention before one has done a very close look at who is actually in the target group, who are we intending to receive the intervention, and being able to capture information about them to be able to say, did we in fact refer the right children to this intervention, and did those children then all follow through and uptake the intervention? And so that was difficult in the wraparound example because, like many interventions, for example, the PCIT intervention that you described in your presentation is very similar in that we're selecting children into this intervention on the basis of factors that are sort of clinical and not present in the administrative data. That's true for wraparound. We select children into the program based on a team meeting that's cross-system, where the program managers communicate with one another about whether particular kids in front of them are, in fact, eligible for wraparound. What I think happens then is that it's unclear. It's unclear who, in fact, is eligible, and as I said, are we selecting the population of everyone who's potentially eligible for wraparound, or is it just simply a little bit of an ad hoc process that is a valid process, but it presents issues with being precise about the population that we're trying to select?
Right.
And
it's an issue with that clinically makes sense, but for evaluation it presents certain problems.
It does. And I think that there are ways of dealing with it that we didn't know at the time, but now we can learn from it going forward, that one can estimate what those factors are that make someone eligible for wraparound. In fact, they may meet certain clinical criteria such that they are, for example, for wraparound, they have to be at risk of a group home placement. Mm-hmm. That's a fuzzy concept. But one can take a look at the data and see, well, what types of factors do kids present with when they do go to group home placement that make them more likely than children who do not have those factors? For example, prior placement experiences or children of certain ages. Obviously, babies are not at risk of group home placement. We can rule them out, right? So there are factors in the administrative data that I think we could use to sort of predict who is likely to experience group home placement and target on that basis. And then one has a more precise capture of the target group.
Okay. And this wraparound evaluation was a post hoc in the sense that the program had already unfolded and then the interest was in then evaluating. So that presented some special challenges too. Tell us about the homeless intervention program, because I know with that program you had the chance up front to really think about this targeting issue. Exactly.
And that was a luxury that I think that we should seek for future opportunities to capitalize on. Mm-hmm. We really learned a lot from that. I think typically in the field we conduct a lot of post hoc evaluations where we roll out a program and then we ask an outside evaluator or an inside evaluator to please go and figure out whether or not this thing worked. And the problems with that include the ability to really understand who was intended to get the treatment and whether those folks in fact got the treatment. In the homeless program, what we have right now is a 5-year federal grant with the Children's Bureau to conduct a randomized controlled trial that is essentially a wraparound type program that's coupled with rapid housing up front. So the target group is homeless families that are coming to the attention of the child welfare system who also present some other comorbidities. Could be domestic violence or mental health or other problems. And the targeting criteria that we settled on somewhat was dictated by what the Children's Bureau, what the feds really wanted this program to be about, but some of it was about what we believed was really realistic in terms of how the program would be effective. So we didn't think that this program would be effective for everyone who met the homelessness criteria. We thought it would be effective for a particular subgroup of those folks. And we were able to select on the basis of those criteria. Those criteria have clinical meaning, but they're not things that aren't, they are things that are present in the administrative data. So that's why it was a really great way to use existing information to say, if people present with X, Y, and Z characteristics that we can measure in the administrative data, they are at risk of placement into foster care to the tune of 90%, 80% likelihood. And then we can use that to say, well, this is the target group for whom we seek to improve that and bring that risk of placement down.
So one of the things we emphasized in the presentation that folks have seen is the importance of choosing a representative sample, and wanted to hear a little bit about how you have had to wrestle with making sure that evaluators, especially outside evaluators, are choosing a representative sample.
Sure, there's a recent example in a program that was implemented, a pilot program implemented in 4 counties in California called Residential-Based Services. It was a pilot study to see whether or not this program would in fact improve outcomes, particularly permanency outcomes and stepping kids down in level of care for children who are placed in very, very high levels of group care. And in the outcome evaluation, the initial year 1 report in the outcome evaluation, the sample selection was a little bit off. And what I mean by that is the evaluators only included in that sample children who had exited the program. Now, one can exit the program either because they completed the program successfully or because they AWOL'd from the program. But in either case, there's a bias there. If you're only restricting your look to children who have exited the program. And so what I did was to have a lot of conversations with the evaluators back and forth to make it clear that it was important to study all of the children who were exposed to the intervention. And that's what's called the intent to treat population. Because it's important that we look at the full sample of everyone who got the program. One could have not exited in a given year for a variety of reasons, good or bad. And so it biases the sample, and we want to make sure we study everyone who got exposed to the treatment, no matter how long.
Right, so this idea of the denominator, choosing a representative sample, is important in the CQI process that folks have heard about already, but it's also really important, obviously, for evaluation as well. So tell us a little bit about the costs and benefits of having an outside evaluator.
Yeah, I'm in an interesting position to be able to think about that, I think, because I've been both. And I think one of the primary costs, and this is one that cannot be really underestimated, is that an outside evaluator has to spend a tremendous amount of time to get up to speed with the particularities of the jurisdiction that they're working in. There's bureaucratic nuance, there are organizational factors, things that affect the ability of an organization to access the target group once it's been identified, to actually find those children and refer them for the services is no small task. It is also very difficult in an organization to implement something new, to train everyone, to do so uniformly. You might experience severe delays in that process. So all of the things that have to go into play before you can ask the outcomes question is very time-consuming and expensive. If the evaluator also has to understand the administrative data, that's a very large issue. very few organizations really do understand child welfare administrative data. Many organizations have worked with various administrative data sets sometimes, but the child welfare administrative data are unique. And very few folks really know how to interpret it and understand it and work with it and manipulate it. So that takes a tremendous amount of time if you're hiring an evaluator who's relatively new to that experience, particularly in California. So those are some of the costs, as well as a tremendous amount of time that has to go into just establishing data sharing agreements, and if there's cross-system data that is being used, which is a terrific thing, and we should be doing more and more of that, it's very, very time consuming. And it probably triples the amount of time you expect, even if you build it in. In my experience, it probably something like triples the amount of time.
So people should really understand what they're taking on when they're seeking to do an evaluation with an outside evaluator. How about the benefits of an outside evaluator?
Well, there's the obvious objectivity, right? That I think is one of the strongest things, and that's probably the main thing. They are also, the objectivity can be related to other things, which, for example, are the ability to stay somewhat outside of all those bureaucratic issues and processes and implementation challenges. However, I think on balance, it's important that the evaluator is actually really familiar with those issues. So I think that it's not that it's a cost that cannot be overcome to have an outside evaluator, but I think that the outside evaluator needs to take an evaluation approach that is not typical as we used to do evaluation in this post hoc way, where they come in after the fact, try to get up to speed on the program, try to get up to speed on the implementation and how everyone was targeted or not. I think it's more important that whether it's an inside or an outside evaluator, that they take more of a CQI approach to the evaluation and are really intimately involved with the planning process all along in order to be best poised to answer the outcome evaluation questions.
Okay, so that's really putting a plug in for folks who are considering if they really want to do an outcome evaluation, to bring in the evaluator early on.
That's
to
right.
help in the design
That's
of the program.
Right. I very much support that.
Okay.
We try to do that.
And so let's say you make the decision, this is an important enough program that you want to do an outside impact evaluation. What do you look for in an evaluator?
Well, I look for so this would be literally reading responses to an RFP, which I've done several times. And so what am I reading for in these proposals? I'm reading for whether, and not in the particular order, but I'm reading for whether or not the evaluator has a good substantive understanding of the subject matter. Many outside evaluation firms are looking for their next contract. They have to survive. They're looking for contracts in a variety of topic areas, in a variety of jurisdictions, and so typically they may be spread thin in terms of their subject matter knowledge. And sometimes it's actually almost always critically important to the evaluation that the evaluators have a deep substantive knowledge of child welfare and the policy and practice issues that are at play. That, even said, still requires a lot of time once the evaluator is hired. So as I mentioned earlier, it takes a lot of time to get all those things in place and that understanding in place. But if they don't have that going in upon hire, they have very little chance of getting the thing done in the amount of time is reasonable and expected. So the subject matter is knowledge, deep substantive knowledge is important. And also some indication in the proposal that the evaluator takes a longitudinal approach to looking at data, that they're not simply going to select a population of all kids at a point in time in the program, or all kids who exited the program in a given year, that there's some indication in the proposal, if not using longitudinal as a key word, then there is at least some indication in there that that's their approach to looking at all children who entered a program, for example. So an entry cohort approach, I certainly look for that. And then I would say they should have good experience with administrative data. That can't be minimized. It's a difficult thing, it's a tedious thing, and not everyone has it, and it's important to have.
Right, some really special skills there. So if an outside evaluator isn't a possibility and you're doing an internal evaluation, what are the kinds, how do you approach doing evaluations inside your agency?
Yeah, I think that one of the first things we do is to ask the basic question. This gets back to the targeting issue. If we're being asked to evaluate a program that's been rolled out for some amount of time, which is typical, we're kind of having to work backwards a little bit and say, let's take another look here and let's ask, before we ask whether the program worked or not, we have to ask, did everyone who got the program, were those the intended kids? Did we in fact penetrate the target population in the way we expected to or wanted to? So, or did we have barriers in terms of kids not getting referred to the program who should have been referred? So answering those questions early is really important. And related to that targeting issue is whether or not children got referred to the program when it was clinically appropriate for them to do so. So for example, this sounds really obvious, but if you want to know whether your program had a placement prevention effect and kept kids out of foster care, you must not enroll the children in the intervention after they've already been in foster care, right? Because they're no longer eligible for prevention. They're now in foster care. So now the goal becomes something else. It becomes perhaps sending them home faster, right? Or getting them to adoption faster. Mm-hmm. But you have to look at the data to say, what was the timing of the delivery of the intervention relative to their foster care experience, and did that match what we intended to use the intervention for? And again, right, as I said, it sounds obvious, but in my experience, that's not a step that we take ahead of time.
Right, well, there's that trickle down, so that's the caseworkers who are actually implementing the intervention. So in the evaluation shop and the management shop, you don't necessarily know how it unfolded. So looking to see, did it impact the children and families with the right timing, as you say, is an important first step.
And I would also say that information is very useful feedback back to the program staff to know, did they in fact refer kids at the time that the program was intended to be delivered? That's a part of a CQI process for the line staff to learn about when they should be delivering this referral to this intervention.
Right. So one more question just to wrap things up. One of the things that I talked about in the lecture are the different types of evaluations. So we have implementation and cost. Those are the two types that don't require a comparison group. They're essentially descriptive. And then there's the outcome and cost effectiveness evaluations, where because you require a comparison group, all kinds of issues around targeting and more complex data work comes into play. Do you think that the outcome evaluation ultimately is worth it in most cases?
Well, I think my answer to that would have been different 2 years ago than it is now. And I think that when I was working solely on outcome evaluations, I thought that was the end game. And now I see, after being embedded in an agency, in a public agency, how important it is to do those earlier studies, the targeting, identifying the population very clearly and precisely, asking questions about whether you've done that adequately, who have you missed, and moving on and doing an implementation analysis to understand, did we in fact implement the thing that we said we would implement, or did we implement something else, or did we do nothing at all? And those things aren't small issues in a public agency or a private agency for that matter, in a real world social work setting. And so if you haven't done those things, then any information you find out about outcomes is not yet relevant. It's not yet enough information. So for example, when we did an outside evaluation of differential response, it was an outcome evaluation. One of the things we learned from that is very few children received differential response at all. Well, that's really important information. How do we know anything about the outcomes when we only gave a light dusting of the intervention across the population? Mm-hmm, mm-hmm. So that leads us to go back and do that earlier work. So ultimately, yes, outcome evaluation is important, but in absence of the earlier work, less meaningful.
Well, Bridget, thank you so much for your time today.
Thank you. It was fun.